the past chair of the section, the adult IDD section. Thrilled that everyone's here, and the discussion on IDD neurologic issues outside the United States is such a huge issue. Obviously, the complication that we face as neurologists is not only US centric, it's everywhere around the world. So how it's provided and viewed and looked at in other countries and other areas around the world is so essential for us, I think, to have some gained perspective. So you're going to hear a number of speakers today that are going to be speaking, and for us to be able to have this move along in a really productive, wonderful way. Tamar Caceres is going to be helping to lead it. I know Tamar is going to do a fabulous job, and Tamar is a leader in our section in neurodevelopmental disabilities and doing excellent work at Rush University Medical Center. So Tamar, if you want to add on to yourself, but basically we're going to cut short so we can leave time for a lot of our speakers, and you're really going to have a great conversation. So Tamar, I'm going to kind of throw it right back to you and kind of help kick this off.
Great, thank you. So as Seth mentioned, my name is Tamar Caceres. I'm a pediatric neurologist specializing in clinical research and care for individuals with neurodevelopmental disabilities in Chicago. And I have the pleasure of moderating today's webinar where we'll get to explore neurologic care of people with intellectual and developmental disabilities outside of the United States and associated challenges and the context in which we practice as neurologists in various other countries. So we have a great panel today of individuals who focus on neurological care and care for individuals with intellectual disabilities, and we'll talk about the impact of care delivery outcomes. So we have speakers joining us today from Switzerland and Zambia and Spain, and hopefully Dr. Voloshin can join us from the Ukraine. Each of these countries has their own unique, geopolitical and healthcare systems that provide a backdrop in which our colleagues provide care. So today I'll start by welcoming Dr. Julia Frosch from Switzerland. She's a pediatric neurology fellow at Basel University Children's Hospital in Switzerland, and she'll be giving us an overview of care of individuals with disability in Switzerland. So thank you, Julia.
Yeah, thanks so much, Tamar. Hi, everyone. I'm happy to be here. Just one second to share my screen. Can everyone see this okay?
Definitely.
Okay, perfect. So as Tamar said, I'm from Switzerland, born and raised, and actually got interested in this specific population because I grew up with a younger brother who has autism and epilepsy, and so was passionate about the topic from, the earliest childhood. And after I graduated medical school here in Switzerland, I actually moved to the United States to do child neurology residency there, and I graduated from child neurology residency at Boston Children's Hospital this past summer, and then moved back to my hometown afterwards. Back in Boston, I was involved in some projects catering specifically to transition-aged people with IDD as well as adults with IDD. And among other things, I worked on building a resident teaching clinic for people with IDD, specifically adults, together with Jesse Sanders, who's also on this call right now. So I want to, give hopefully an accurate representation of my home country. And first of all, I want to start by saying that, Switzerland is a very small country. It's not to be confused with Sweden, which is much bigger and in the north of Europe, but Switzerland is much smaller with a population of just under 9 million. And it was recently listed as the 8th wealthiest and the 3rd happiest country in the world. So just to give you some statistics right off the bat. But I think we can't really talk about the care of people with IDD in Switzerland without also talking about kind of the societal framework in which it happens. And so I thought that a good way to do this would be to actually talk about the UN Convention on the Rights of People with Disabilities, which is actually a convention that's based on the Americans with Disabilities Act, the ADA. So Switzerland ratified this convention back in 2014. And I think it's actually noteworthy that before 2014, people with disabilities in Switzerland did not have a constitutional right to inclusion. So I think that that's pretty interesting. And so this past year, 2022, the UN actually sent in a commission to do an evaluation of Switzerland's compliance with the convention. And unfortunately, the report that they issued was giving pretty poor grades to Switzerland. And so I figured I would just share some screenshots from the actual report. You can find the link below here and access the whole thing. But these are just some screenshots that I thought were worth highlighting. So first, the committee noted that in Switzerland, there was a lack of awareness about the dignity and rights of persons with disabilities, both in society and in the media. They noticed that there was an over-reliance on civil society organization to conduct awareness-raising activities. And they also mentioned that there were discriminatory attitudes and negative stereotypes towards people with all disabilities, but including autism and intellectual disability. They noted that there was use of forced medical procedures and treatment, that there were various forms of restraints being used, that there was seclusion in prisons, residential care facilities, and psychiatric institutions. They noted that there was institutionalization of adults and children with disabilities, including ID and autism, and that there were reports of violence and abuse in these institutions. And that there was a relative lack of a comprehensive system to essentially foster more inclusive housing and educational opportunities. They also mentioned that there were numerous barriers to medical care, both primary and subspecialist for people with disabilities, and that there were also some cost-related restriction, and that there was a relative oversupply of, for example, inpatient and institutional psychiatric treatment options, whereas there was a lack of, community-based mental health services that were being built. And then as my last example, I'll say that the committee noted that there was no comprehensive disability data framework where data and statistics on people with disabilities were systematically collected. And so I think all of that is a bit of a hard pill to swallow for a country that is so well off in general. But I think this last point is interesting in a specific way, which is that, really there are very little data on the whereabouts of people with IDD in Switzerland. For example, I was not able to find a good number on the current prevalence of IDD in the country. And, specifically, I felt that there was almost like a data gap between kind of the information that is put forth by some of the government entities and the information that is being published by some of the big disability advocacy organizations. So for example, government entities really don't have a lot of detailed information about IDD specifically. Most of their disability statistics include all disabilities, whether they were acquired early or late in life, or whether they're neurological or other. And one example is that, if you look at one of the government websites, they quote very, high levels of happiness and contentment with living situation among people with disabilities. But at the same time, a lot of the advocacy organizations actually say that there is a big number of people specifically with IDD who are unhappy with, the choices they have of where to live, that there is relatively poor accessibility and so on and so forth. And so since we don't really have good statistics to actually prove that there are ongoing healthcare and societal disparities, that just also makes it really hard to kind of argue and advocate for changes to be made to the system as it is now. Now, a few words about services that are covered or not covered. So as some of you might know, Switzerland has essentially universal healthcare, where it is mandatory for every citizen to have healthcare. And what's covered, for example, is early intervention for kids. That's free of charge, no discussion. What's also covered is attending a special education school, as long as it's attached to the public school system. But it's important to note that those are usually separate school buildings that are segregated from kind of the mainstream schools. Also completely covered is the cost of living in an institution. And then what's usually covered is kind of the whole medical workup piece. Usually we get coverage for genetic testing in IDD, EEGs, imaging, and so on and so forth. On the other hand, what's not covered are some, disability-specific supports that go beyond kind of just early intervention and public special ed schools. So for example, ABA therapy for people with autism is not covered. What's also not covered is care work by relatives, which I know many places it's not. And then what I kind of put in the middle, but really more on the not covered side is, supports towards more inclusive forms of living and employment. There's definitely some improvements being made, but I would still say that there is a financial incentive for patients and their families to attend the more segregated settings, just because there is a high supply of those and the cost is, pretty much always fully covered. But now I want to talk about, some more positive things. And I want to give some, positive examples from the hospital where I currently work. So on the picture here, you see the Basel University Children's Hospital. It's a freestanding clinic. I will point out that the exterior actually changes color, kind of like a mood ring, which I think is really neat. So it's a really nice building and it's pretty new. And so our department is actually a combined department for developmental pediatrics and child neurology. And they have many kind of multidisciplinary clinics. There is a multidisciplinary CP clinic, for example. There is an autism clinic. And I would say that in general, the workup and etiological approach to IDD is relatively similar to what I know from the US. And also, has, I would say, a relative good kind of financial coverage situation here. One thing that I think is maybe interesting to point out just for people who come from the American system is that in Switzerland, kids actually age out of pediatric care a bit younger than they do in the United States, which for me as somebody who's interested in transition, I think is interesting. So the typical kind of age to leave pediatric care for the general population is around 16 years or maybe 18 the latest. I know that some of the child neurologists here are able to keep their patients into their early 20s, but definitely there's more families, I think, are a little bit more in a time crunch to kind of get all of their ducks in a row, get guardianship and things like that figured out. And then actually, I think what's a real positive aspect is that there is actually already a number of transition clinics in place at this hospital and the partnering institutions. So for example, there is one transition clinic for patients with epilepsy and sleep disorders from child to adult neurology. There's a great transition pathway for patients with CP. However, there is, I would say, based on my discussions with faculty here, a relative lack of kind of adult care options for people with autism and more of the neurobehavioral kind of diagnoses. So that still seems to be kind of a struggle to find adult care providers. So with that, I hope that I was able to give you a little bit of an overview. I think Switzerland has this really interesting dichotomy where there are a lot of resources there and people with IDD generally have their needs met in a way that they have housing, they have insurance, they have school, they have money for food. But at the same time, there's a relatively high level of segregation. And I think that also leads to kind of a relative lack of awareness of some of the healthcare disparities that might still exist. And with that, I want to end with this pretty picture of my hometown, and I hope you can all come visit. And yeah, I'd be happy to take questions at the end of the webinar.
Thanks so much, Dr. Frew. You really captured some of the things that I think will be interesting in hearing from all of our speakers today in terms of how things look in resource-rich areas, how things look in more resource-limited areas, and the differences in approach, with a universal healthcare system, how individuals are incorporated into education, or if there is more of an inclusion approach versus an institutionalization approach. So thank you. Next, we'll hear from Dr. Taras Voloshin. He's a neurologist in Ukraine at a group of rehabilitation clinics in a number of different countries, focusing on physical rehabilitation in individuals with neurodevelopmental disabilities. So if Dr. Voloshin, if you can hear us, you are welcome to share your screen and go ahead. Thank you for joining us.
Yeah, hello. Good afternoon to everyone. Can you hear me well? Yeah.
Yeah.
Yes, you sound great. Thank you.
Yeah. Okay. So unfortunately, as the last time, we have no lights here at the apartment, and it's really let's say a tackle to take part in the meeting when you have no light. So currently I am working out of my phone and giving a presentation out of my phone. So
we really appreciate your efforts to join us in your current situation. Thank you.
Really I try to turn on the camera and it all looks black. So let's. So it doesn't look nice. I may try one now, but in fact,
We see you.
that's what happens. So all black. All the streets are black. My apartment black. Yeah, so
Wow.
nothing.
Yeah, yeah. So why don't you tell us about the work that you're doing at your rehabilitation clinics?
Yeah. All the city is, let's say, it's really, it's around like 10% of the city lights and 90 don't. So sorry for a brief introduction of what's going on in Ukraine. About our job, about our care. So let's say we work for more than 30 years, and we used to work in Ukraine only till 2014. So we are brand new internationally, but we have a huge experience of working in Ukraine. We have facility in Central and Eastern Europe, and our method of rehab primarily is based on the influence on the spinal component. So let's say it's a way of manual therapy adapted to the child's combined by around 12 therapies that are daily to each child. So it's let's say it's a very intensive system of treatment that combines different treatment modalities influencing the muscles, muscle tone, intellectual development, fine hand function, walking, all gross motor functions, vibrations, stimulations, and so on. So that's a lot of stuff. Also, we have lots of potentiating parts like Olympic Games among kids with CP or among autistic children that allow us to contribute to their motivation part. So let's say about our international experience. So our first branch appeared in 2014, and that were patients coming to Larnaca. So it was our first international branch. Till that time, we had many international patients from 68 countries of the world in Ukraine coming to Ukraine. In 2014, the war started, and we had to switch to be able to receive our international patients to Cyprus, where we had more than 60 patients. At the time, we had around 200, 250 patients each treatment cycle in Ukraine. That was the first experience. After we had to switch to other facilities like UAE, to United Arab Emirates, where we opened in Al Ain and in Abu Dhabi. And currently on 11th of February, we opened in Kuwait. In United Arab Emirates, we work together with Cambridge Medical Rehabilitation, and we are implemented within all their facilities in UAE. And the next opening center that's gonna open, that's in Saudi Arabia, in Dhahran. It's on the west, near the Red Sea, near Bahrain. So that are the nearest plans. Yeah, so mostly we work with cerebral palsy cases, and we work with autistic kids and all motor disorders, all problems related to motor delays, to anatomical changes of the joints, of the muscles, both inherited, congenital. Let's say it's like a rehab institution, but we take part in many international meetings. So around 10 to 15 countries I visit annually. So now the next flight, it will be my 9th flight this year. I'm the only one that may leave Ukraine from the whole clinic. So this is the reason why I'm traveling a lot last year and this year. But we hope the war will finish soon and we'll have a chance to live a happy life in our own country without any, let's say, foreign interventions, and staying calm and doing our as usually. So I hope to see you also in Boston. I'll go to Boston to AN conference as won their international award, and hopefully we'll see you there as well.
Thank you, Dr. Voloshin. Yeah, it's really amazing, the work you're able to continue doing in the context of the war in your country. And we're so, appreciative that you were able to join us today. And, the physical rehabilitation approach that you are spearheading is really quite a distinct approach of care for individuals with intellectual and developmental disabilities, whereas in other settings, the focus may be more on behavioral strategies or skill building. And so, it's really wonderful to get to hear more about the work that you're able to do. Next,
unfortunately, I have no chance to show slides now, but let's say if we speak about intellectual and developmental disabilities, so majority of, well, let's say, kids with autistic disorders, around 70% of them, they have neurological underlying cause of the disease. And what we've encountered when providing comparison of logopedic massage, psychologist influence, therapy influence, and combining them or comparing them to a approach, let's say fine hand function development, influence on the spinal cord, on the cervical area. So let's say physical influence was not less important and not less efficient than the first one.
That's very interesting. I think that it will be exciting for us to continue to learn more about the work you're doing. Next, we'll be hearing from Dr. Mfwama Kawatu, who's a pediatric neurologist in Zambia at the UTH Children's Hospital in Lusaka, Zambia, to share her experience providing neurological care for individuals with developmental disabilities in Zambia. So thank you for joining us, Kawatu.
Thank you very much for according me this opportunity to talk to you about the experiences of disabilities in Zambia. So I'll talk about the Zambian experience. Our experience in disabilities is not as vast as the Western world, because as you know, we only started our neurology program. And not only that, compared to the number of years that the country has existed, we are still a young country. So I'll start by telling you about my country. Zambia is a very beautiful country in sub-Saharan Africa, in the southern part of Africa. As of 2022, our population was a little over 20 million. In 2015, there was a survey that was done. That was the last survey that was done on disability. And it was noted that 7.7% of the population is disabled, and this disability is in various forms. Of this 7.7, 4.4% were children, and 4.2% of these children live in the rural areas, while 4.6% of them live in the urban areas. I must say that these percentages may not be exactly accurate, because there are some children who live in refugee camps which could not have been accounted for. The causes that were identified were that most of them had birth or congenital defects, and 31% of those were due to diseases and illnesses like malaria or meningitis or tuberculous meningitis. So some of the challenges that face our children here with disabilities. And when I say disabilities, I mean both physical and intellectual disability, are the access to care. And this access to care is on two sides of a coin. It's an advantage as well as a disadvantage. For example, a child that's coming from a rural community, on the advantageous side, a child that's coming from the rural community will be identified in the community by a community health worker and then referred to a health post. Then from there, they may be referred to a health center. And if the problem is too big, to a first level hospital, and eventually they'll reach there that sees children. The downside to this is that the process of reaching specialized care is then lengthened depending on where you are in the country. The other challenges that are there are stigma. Some children are locked up in homes because they are not considered to be normal. The environment they live in is not conducive. I mean, up to 24% reported that they had difficulty accessing buildings, schools, and office spaces, markets. If it's the transport system, we have little small buses to go around. The ones that you would refer to as vans, that's what we used to go around for public transport. But on top of this, access to care is the biggest challenge, because most of it is not affordable. Sometimes it's not accessible. In some areas, it's not available, and it may not accommodate everyone. And sometimes, depending on which family or which religion or which culture you come from, it's not acceptable. So all these problems have led to the government implementing structures to help these children, but also identifying that there's a gap in treating children with disability. So according to our 2015 survey, 85.7% of children had no access to assistive devices, and an alarming 100% had no vocational training at all. 49% of these children, almost half of them, could not get educational services because we have inadequate special schools in the country. In terms of the healthcare workers side of things, we only graduated our first 2 child neurologists starting the program in 2018. And prior to this, we had services which were dependent on visiting experts that would come and go out of the country. As at now, the 2 of us are servicing a population of about 20 million people. And even with that, we have limited access to diagnostic tools, occupational therapists, physiotherapists, speech therapists, and child psychologists. So, however, our government has put in place various policies over the last few years in order to give a good service to our children. And the first step they did was have a disability survey, because we did not even know how many of our children and how many of our people suffered from lived with disability. So in 2004, we had a disability survey, which then brought about the birth of the Disability Act of 2012, which promotes the participation of persons with disability with equal opportunities in all spheres. After this, we had another survey in 2015. However, this 2015 survey did not even categorize the various disabilities. They would talk about the physical disabilities, but when it comes to intellectual disabilities and other neurodevelopmental disabilities, these were not particularly categorized. Also coupled with this is because I think most of the kids are not diagnosed, like the ASDs and kids with ADHD and other intellectual disability are not really recognized early as possible in order for them to be part of this prevalence study. In 2022, August of 2022, a law was passed. The law, we call it the Children's Code, and this law kind of solidifies the rights of the child with disabilities, and now it's a punishable offense to abuse these children. On the side of us as neurologists and disability, we have a developmental intervention clinic at the hospital where I work, and it was established in 2011. This is a multidisciplinary assessment clinic for early intervention of children with various disabilities. We also carry out neurological assessments, including assessments and history taking of other children with epilepsy or any other neurodevelopmental disabilities. Some of the assessments that we do are speech and language, behavior, occupational therapy, and in the past, before 2017, we could do cognitive and learning assessments and psychosocial counseling. These two have since fallen off due to lack of funding, because this was a CDC funded project. And from 2017, most of the CDC funded projects kind of like fell off. We also offer parent and caregiver focused care through home-based and caregiver education programs. Aside from that, we do early interventions, especially for children aged between 0 and 7 years, where we see kids with cerebral palsy, feeding and swallowing difficulties, intellectual disability, ASD, ADHD, and other congenital acquired disabilities and conditions. These conditions are also part of our capacity building, where we train healthcare providers, not only from the capital city, Lusaka, but also in other centers like the Copper Belt, which is the second largest populous province in Zambia. And we train healthcare workers, teachers, and community healthcare workers on the recognition and management of children with neurodevelopmental disorders, and neurological evaluation of school-age children with appropriate referral to the required service when needed. Also, we support the children's caregivers by giving them resources and referrals to service providers. Nutritional counseling, we know, is very important, especially with children with cerebral palsy. And we refer them to the appropriate service providers and advise and support for the families on school placement. We also do some research in neurological conditions. We have a research center, which is supported by Professor Bierbeck. This picture here shows a special school that is located in the premises of our children's hospital, where we see over 100 children with disabilities get an education, and it's for free. And the second picture here shows our speech and hearing center, which does audiometry and speech assessment and speech therapy for most of our children with autism. Lastly, I would like to thank our team. This is our team at the Neurodevelopmental Clinic, and in the middle there, somewhere in the middle, is Sister Onela, who established the Developmental Intervention Clinic, which is helping children with disabilities. Thank you for listening.
Thank you, Dr. Kawatu. I think, one of the things you mentioned was the sort of 5 A's of challenges to access to care for individuals with intellectual developmental disabilities, which I think are barriers felt all over the world. And you also raised some important challenges with epidemiologic research in individuals with intellectual and developmental disabilities to better understand the population so that we can know how to provide care. So next we have Dr. Juan Fortea, who's joining us from Barcelona, Spain, where he works as the director of the Down syndrome unit at the Hospital of San Pau. And so he will be sharing his work in Alzheimer's care for individuals with Down syndrome. Thank you for joining us, Dr. Fortea.
Thank you very much. Can you see the screen?
Yes, we can see the screen. Thank you.
Fantastic. Thank you. So I'm an adult neurologist, and I'm going to talk about the other extreme of life, which is the Alzheimer's disease and the medical problems, but mainly Alzheimer's disease in adults with Down syndrome. And I want to justify a bit, because I think that in some instances it's not everyone realizes the importance of this disease in the context of Down syndrome. So I'm going to try to convey both what we've done and why we've done it. So, I think that DSAD is a genetic form. Well, DSAD is a genetic form of Alzheimer's disease, and this is a huge statement. This means that anyone with Down syndrome has Alzheimer's disease, even if they don't have any symptom. And this is a very, very strong statement, as I say. And of course, we have to realize that the epidemiology of Down syndrome has changed dramatically. The life expectancy now reaches almost 60 years in most developed countries, and this means that contrary to what many people think, the number of people with Down syndrome has increased dramatically. And now we have more people than ever with Down syndrome, mainly adults with Down syndrome. And this is the cumulative risk of Alzheimer's disease in Down syndrome. If you take away the survival bias and you follow people long enough, this is data from Mary McCarron in Ireland, over 95% of people with Down syndrome develop Alzheimer's disease. And this is because of the full trisomy that is in most cases that has in chromosome 21, and that's where the APP gene is coded. And if any one of you had 3 copies of APP, you would also develop Alzheimer's disease with full penetrance. And this is the case for people with Down syndrome. So what we did in Barcelona is over 10 years ago, realizing that the importance of Alzheimer's disease in this population, we took advantage of the presence of the Catalan Foundation for Down syndrome, which is a charity, a very large charity in Barcelona that works to help people with Down syndrome in many ways, and also from a medical perspective. Actually, in the 80s, when people with Down syndrome were not well attended in the public system, they provided a specialized clinic in which families with individuals with Down syndrome could come and be attended. Things have changed, and I think the system now takes better care of adults of children and adults with Down syndrome. But still, I do believe that even in the context of public health systems, such as the one we have in Spain, it's important to create a specific program. So, because I mean, one size fits it all is not the right strategy, especially with people with intellectual disabilities. MDs do not feel qualified or have the time or knowledge to have and create proper care. And so what we did is, as I say, created a health plan to screen for people with Down syndrome. And we offer a free annual medical and neuropsychological assessments in our hospital. And in the last 10 years, we've been able to evaluate over 1,000 individuals with Down syndrome. And on top of that, we've also nested a biomarker research program in which we offer a lot of multimodal assessments to study the Alzheimer's disease in this population. This is a picture of where we attend the people. So it's not the actual new hospital. We have a small building that is not in the hospital, and this was as per request of the Catalan Foundation for Down syndrome. They said that in order to perform a screening program, they wouldn't like to go to the hospital because most of them would not be ill, and they didn't like the idea of going to a hospital and for annual checkups. And I know that in children this is common, and the pediatrics, but in adults we don't have this kind. We usually don't go to the hospital if you're healthy, and they were very sensitive to discrimination, and they prefer to have like a more a different space. And so we taking advantage of the history of our hospital that has separate buildings, we were able to create a program in a building that where the ambience, the environment, if you will, was more agreeable. And so just to, so this is our photos of some of the neurologists examining the patients with Down syndrome. And just so you realize the ultra high risk of progression in the AD continuum. So if you have prodromal AD in 3-5 years, you will have AD dementia for sure. But even if you're asymptomatic, this is for the different age ranges. And so just take a look at the red line here. This is people over the age of 50. If you follow them for 3-5 years, 50% will develop Alzheimer's in the next 3-5 years. So imagine what that means. And this is asymptomatic people from the general Down syndrome population. So this is the ultra high risk of to progression to symptomatic AD they are facing. And this is because in the end, DSAD, you can anything that you know autosomal dominant Alzheimer's disease, you can most likely or have the presumptive hypothesis or the hypothesis that it will apply to Down syndrome. So this is, for instance, a paper that we published 2 years ago, in which we demonstrated that the natural history of Down syndrome was exactly the same or very, very similar as to that described in autosomal dominant AED. In agreement with this conceptualization of a genetic form of Alzheimer's disease. In a follow-up paper, we did a meta-analysis, and we, with all the studies that have been published in the literature in Europe, the US mainly, but also in other parts of the world, in which we could say that the age of onset was very much conserved. And so in this meta-analysis, the mean age of, for dementia was almost 54 years. And what's important is that it was predictable. So this age was as preserved, as predictable as in autosomal dominant AD. As you know, in autosomal dominant AD, if you have a presenilin 1, your father has had a presenilin 1 mutation and developed Alzheimer's at 48 years, you are bound to have Alzheimer's disease around 48 years. It is the same scenario, and with the same variability as we demonstrated in this paper for people with Down syndrome. So, and this is the what we did and the why we did it. And just to summarize, DS is a genetic form of Alzheimer's disease with near full penetrance, that AD pathology and biomarker changes are similar to those described in sporadic AD, and that specific health plans are imperative to diagnose and treat Alzheimer's disease. And I would say that for all comorbidities in adults with Down syndrome. And I like to end up with this statement that AD might be easier to cure in Down syndrome than in the general population, and that not to perform research is just a form of discrimination and a huge missed opportunity. And this is the team that we see people with Down syndrome and the wider memory unit. Thank you very much.
Thank you, Dr. Fortea. I think that you really emphasized an important aspect of care for individuals with intellectual disabilities, that it's important to better understand neurologic conditions that they are predisposed to, and that may look different in different parts of the world based on life expectancy. But it's important that we all work together to provide equitable care for individuals with intellectual disability. So I'd like to open up to questions from our audience for any of our panelists regarding any of the things that they've spoken about today. Is anybody? I don't see any questions in the chat yet, but please either unmute yourselves or go ahead and ask questions.
Can I just add a comment?
Absolutely.
Yeah, real quick. I mean, please let us know, real quick, if you can all let us know where you're from. We know who our speakers are from. We don't have, tons of people on it. I know this will be archived, but in the chat box, please let us know where you're from. My only comment, and this is certainly related to pediatric neurology and one spectrum of those being born with developmental disabilities, and those, as Juan, as you're talking about, in the older population, and the reality is that in Down syndrome, you're eventually going to see it progression, losing their skills, and it'll be Alzheimer's disease, is it really has a lot to do with the cultural, social issues around the world about people living longer or not. So really what it is, and I don't want to speak for, I'm in the Philadelphia area in the United States. So basically, if people are living longer and the longevity in the United States is up and up and up and up, we are definitely seeing people aging, not only with Down syndrome, age-related decline in Alzheimer's, but other people who are normal aging and developmental disabilities. But in other countries who don't have early intervention or proactive approaches within their healthcare system or their social system in their countries, then it's really very different. I mean, you're really going to see such a dichotomy. I had spent a week or two back in June in Ukraine, and Taras will certainly speak as a Ukrainian, and I saw it from a very interesting cultural perspective. I was there as an advocate on an organization called Disability Rights International to kind of go to countries, not specifically pointing out Ukraine, but because of the nature of institutionalized care and devalued of certain populations. And Ukraine is just one of many prior Soviet Union countries on how they valued or devalued their population. People are basically, at least what I saw, were not living very long early on, and they never reached longevity. And so even early onset Alzheimer's, they weren't there, and they weren't there because they weren't living long enough. So these issues are very relevant based on what part of the world you are and the resources. So it's just more of a comment that I just wanted to make.
So,
Thank you.
Can I make
Yes,
a comment?
please.
If I can, and I would like to share another slide because I fully agree with what said, and this is a slide that I think is very. So I would like to. This is the CDC data from the US, and so this is the life expectancy in the last 50 decades, 5 decades, sorry, 50 years. So 1970 to 220. And so, for instance, and what you're seeing here is the age in the y-axis, and so every line it represents a different percentile. So this is the 90th percentile, the 75th percentile, the 50th percentile, the 25th, and the 5th percentile. So as you can see, most people in the 70s weren't living beyond the age 20. As you can see, the 50th percentile is the blue line here. Okay, so, but look, this is between sex, males and females, it's not a huge difference. But look what happens between race in the US. The socioeconomic status between Black and white people are completely different even today. And as you can see, there is a huge gap for every percentile. So it is certain that if you die of other causes that are treatable, that are susceptible to health inequalities, then you're not going to develop Alzheimer's. But nowadays, because most people get treated, the conditions, they start to live longer. And now this is the cardiac congenital, as a cause of death, it has declined over the years because people get treated. And this is the reported deaths due to Alzheimer's disease. And this is a huge underestimation in our view. This is the actual reported data, the CDC data. And I don't have time to enter into the maths, but we believe that now it's around 70% of adults with Down syndrome in developed countries are dying of Alzheimer's disease. So true, if you don't treat the conditions, they die. They are hugely vulnerable to inequalities. And this, I think, a very impressive slide shows about the racial inequalities in the US. And so I couldn't agree more.
Thank you. Yeah, definitely. Buma also just highlighted a quote from you that not doing research regarding this population really is a form of discrimination, and that it's important that we better understand adults and across the lifespan of the neurologic challenges faced with individuals with
I have a
developmental
question,
disability.
given the amazing research is, I agree, so huge in moving this forward, but have you had other strategies, or any of the panelists, because I know a lot of us in this group that we meet as together, a lot of us are working on how do we improve access to care for adults with neurodevelopmental disorders. And so given the awesome progress in research on Alzheimer's and Down syndrome, or also the amazing progress in Zambia and in Switzerland and inclusion, have you found strategies that we could learn from to help these adults with Down syndrome be treated in adult neurology practices? Or would just love to hear from your perspective to help us learn.
For strategies for capacity building across the board for how we improve access to care.
Yeah, I guess specifically starting with Dr. Portea, how do you get these patients from the research lens to clinical care for adult neurologic issues?
So thank you. So I think it's the other way around. So I'll give a longer answer. But we had if I may, a talk to prepare this session the other day, and it was very interesting because Fuama said that the oldest person she had seen in her cohort was 40, and our mean age of our cohort is 42. So people need to live longer to develop Alzheimer's. So this is what I meant, and what Seth was saying. If you don't take proper care while they are children, you're not going to have any Alzheimer's. So you have to treat the comorbidities for people to live long enough to develop Alzheimer's. And another very interesting line of argumentation that we had the other day is that Julia, she works in Switzerland, so it's one of the richest countries in the world, and she said that there the care for people with disabilities was suboptimal in the sense that they are not being taken proper care. And I believe it's the same it was our impression in Spain. So what we realized that you can have a good health system in general. You can have an even universal health system, a public system which theoretically it has no inequalities, but this is not enough. I think that we can learn from the child with the pediatric experience, in which you need to have like these proactive health programs, and I think this Down syndrome are a vulnerable population that require adult health programs to take care of the comorbidities. The general practitioners are not going to be able to take care of it. And so, as to put you an example, in Alzheimer's disease, I've always worked in reference centers for Alzheimer's disease in Barcelona. And before we developed this program, we had very, very, very few people with Down syndrome, and they were there, but they were completely non-diagnosed. So that's why we created in this program with the Catalan Down Syndrome Foundation. We convinced the government to get some support, and we encourage people to come and get a screen. And then we have dozens, hundreds of people with Alzheimer's disease diagnosed. Otherwise, we were missing them. And the research, of course, has helped us to build the program. I mean, without the research money, we wouldn't. So it's like a virtuous circle, as I wanted to say. But people are participating in research because they're getting care of. And so that's what I say to my colleagues in the US. Sometimes you have the ABC Consortium. It's a fantastic initiative in terms of research, but sometimes they are struggling to get recruitment or commitment and everything. But that's because if you're only providing research separate from healthcare, people are less committed. I mean, they're getting less out of you. If you are doing like a holistic approach in which you're providing care and also offering research opportunities, I think that's when you start having. So in short, I believe that we have to expand the kind of pediatric programs into the adult age. I think that this vulnerable population cannot be left alone in the system. It doesn't matter if it's public or private. Of course, sorry, it does matter a lot, but it is not enough that they are public and equitable in theory, because they will not provide enough care if they are only on a GP per demand basis. We are not going to take proper care, I believe.
Thank you.
Nafoma, do you, like the 42-year-old that you have, is that cared for by your child neurology team? Or how do you guys deal with that in Zambia?
He's actually a relation of mine, and he currently is not seeking and he's not going to any hospital, any clinic for his Down syndrome. He's just somebody that the family has accepted and has reached that far. But in addition to what Juan was saying, I hope I pronounced your name correctly. I think to answer your question on how to take care of adults with disabilities, intellectual disabilities, the first step for Africa and for countries like mine are to have a prevalence. We've done a prevalence study according to a survey, but also just to know how many are in that bracket. After that, we need to establish like a transition clinic or a transition hospital or a transition something, a policy for transition, because imagine having a child, like I see this a lot. I see up to 24, 25-year-olds in my outpatient clinic because I kind of don't trust my adult colleagues in the sense that the system, the health system that's there doesn't really help these children transition from pediatric care to adult care. And once we bridge that gap, then the adults who have intellectual disability, especially that started in childhood, have got better care and better access to and better quality of life. So I think for me, the take-home message, listening to everybody, is number one, identify, have them acceptable in society. And number two, transitioning from pediatric to adult care must be a stepwise and all-involving and all-encompassing kind of way. Thank you.
Thank you. You know, I think that the challenges surrounding transition are certainly things that we all are constantly wrestling with to try to figure out how do we build capacity on the adult side? How do we help our colleagues feel more comfortable providing care for individuals with intellectual disability throughout the lifespan? There's a question from Dr. Sanders for Dr. Kawatu. Do adult doctors in Zambia, will they see individuals with disabilities?
Yes, they will see individuals with disabilities. It's just that we have silos, let me put it like that. You have the doctors that are compassionate enough and they have the empathy for children and adults with disability, but the system does not allow for you to take over management. It will have to take me calling a colleague that I know that is in a particular clinic, not only for intellectual disability, but even for other chronic conditions like diabetes or stroke kids. I'll have to call a colleague and let them know I'm sending you this patient to your care. Now, the disadvantage that we have is that this is a small cohort of doctors at the tertiary hospital. But there are those patients that are in the community, those that are going to the rural health post, those that are going to the rural health center. Those may not have the opportunity or the chance for somebody to actually take interest and hand them over to the next colleague for their continued care. But we do have adult neurologists, we do have adult physicians who take care of people with disabilities, because I mean, disability can happen even at 60, and that's where it happens the most because of other non-communicable diseases like stroke and diabetes. So there is that. It's just the problem of, I'm a pediatrician, so I always think about transitioning not the child, but the whole family into the adult world. So that the system is what fails us most of the time.
Thank you, Dr. Kawatu. Unfortunately, today we're out of time, but you know, I think that we've had an excellent overview of while we all work to support and provide equitable care for individuals with intellectual disability and neurologic conditions, we do that within a specific system. There's a huge, you know, variability with the impact of the health systems and geopolitical conflict and access to resources. And so there's a lot of value in sharing our approaches with each other to help us learn how to improve care globally and address those inequities we face. So thank you everyone for joining us today. Did anyone else want to say a final word before we finish up for this afternoon?
Well, hopefully we'll have more tomorrow. I mean, we've got a few countries, but hopefully our continuation of other webinars and reaching out to the global community, this is just wet your whistle. This is the beginning, and hopefully other countries, other people, other colleagues also will hear stories and listen and then collaborate. What else can we do? So appreciate everyone coming on.
Thank you. Thank you, everyone.
Thank you, everybody. Have a good day.
Bye.